Nursing Care of Substance Use and Addictive Disorders. Module 6, Treatment Continuum, Recovery and Nursing Care Planning. Substance use disorder is a chronic condition. Recovery is not a single decision. It is not a 30-day program. It is not detox and done. Recovery is a long-term process that includes stabilization, treatment, relapse prevention, and rebuilding a life. As nurses, we do not just treat withdrawal. We support sustained recovery. That means understanding the full continuum of care and knowing where your patient fits. Treatment occurs across multiple levels of care depending on severity and safety. Detoxification is for acute withdrawal management. It addresses immediate physiological instability. Inpatient or residential treatment provides structured 24-hour care for individuals with high relapse risk or unstable environments. Partial hospitalization and intensive outpatient programs provide structured therapy while allowing patients to live at home. Outpatient care includes medication management, therapy, and recovery support. Long-term recovery may include sober living environments, peer support groups, medication for opioid or alcohol use disorder, and ongoing counseling. Not every patient needs every level. Placement depends on medical stability, psychiatric stability, social support, and safety risk. Medication treatment for substance use disorders is evidence-based standard of care. For opioid use disorder, OUD, medications such as methadone and buprenorphine help stabilize brain chemistry, reduce cravings, decrease withdrawal symptoms, and significantly lower the risk of overdose and death. For alcohol use disorder, AUD, medications like naltrexone, which comes in daily oral dosing and in a monthly injection, and acamprosate can reduce cravings and support sustained recovery. Disulfiram works differently. It discourages alcohol use through aversion therapy, classical conditioning. When alcohol is consumed while taking disulfiram, symptoms can begin within 5 to 10 minutes and may include flushing, nausea, vomiting, palpitations, and hypotension. The reaction is intentionally uncomfortable, creating a conditioned avoidance of alcohol. In severe cases, individuals may experience arrhythmias, myocardial infarction, seizures, or cardiovascular collapse. Importantly, these medications are not substituting one addiction for another. They are treating a chronic brain disorder using pharmacologic support, just as we would treat diabetes or hypertension. As nurses, our role includes monitoring adherence, assessing for sedation or respiratory depression when indicated, evaluating side effects, and encouraging engagement in counseling and recovery supports. We reinforce that medication-assisted treatment is most effective when combined with behavioral therapy and ongoing psychosocial support. Relapse can occur. It does not mean treatment failed. It means the disease requires ongoing management. Triggers include stress, trauma reminders, social cues, untreated depression, and lack of support. As nurses, we respond to relapse with reassessment, not judgment. What happened? What support is missing? What needs to change? We reinforce safety first. Assess overdose risk. Assess suicide risk. Reconnect the patient to care. Recovery is not linear. Progress often includes setbacks. Care planning for substance use disorder includes both physiological and psychosocial components. Nursing diagnoses may include risk for injury, imbalanced nutrition, disturbed thought processes, ineffective coping, risk for suicide, impaired social interaction. Interventions may include monitoring withdrawal symptoms, administering medications as prescribed, providing education about triggers, encouraging participation in therapy, promoting sleep hygiene, supporting healthy coping strategies, connecting patients to community resources. Always individualize the plan. Always involve the patient in goal setting. Short-term goals may focus on stabilization. Long-term goals focus on recovery and functional improvement. Not all patients are ready for abstinence. Harm reduction meets patients where they are. Examples include naloxone distribution, safe injection education, needle exchange programs, fentanyl test strips, safe medication storage. Harm reduction reduces death and infectious disease transmission. It keeps patients alive long enough to pursue recovery when they are ready. For NCLEX, remember this: preserving life is always a priority. Recovery requires stability, housing, employment, transportation, access to healthcare support systems. Without addressing social determinants of health, relapse risk increases. As nurses, we connect patients to case management, social work, community programs, and peer recovery services. We advocate, we educate, and we coordinate care. When caring for patients with substance use disorder, always prioritize airway, breathing, circulation, withdrawal risk, suicide risk, overdose risk, medical complications. Stabilize first, then educate, then plan long term care. Remember, substance use disorder is a chronic brain disease. Medication saves lives, relapse is common, compassion improves outcomes, and your presence as a nurse matters. Substance use disorder affects individuals, families, and communities. As nurses, we bring clinical knowledge, emotional steadiness, and evidence based care. You are not just managing symptoms, you are supporting human beings through one of the most vulnerable experiences of their lives. That is powerful work, and you are capable of doing it well.